Sure. Hi, Dr. Brian Kaufman here on the last day, the last minutes here of ASCO 2014 with my physician taking care of me at OSU, Dr. John Byrd. Dr. Byrd, do you want to introduce yourself?
Yes, hi, this is Dr. John Byrd. I'm a professor of medicine at Ohio State University and the director of division of hematology there.
So Ibrutinib was approved a few months ago in February, so it's available. So one of the things that the patients in the community would be looking at is how should this be used? Should it be used in combination? What kinds of things to look at? What kinds of things to expect when they're getting it outside of a clinical trial?
Yeah, that's a common question. Probably the most common thing I'm being asked as as an expert in this area. And really right now, when you look at the studies the phase 2 studies that have combined Ibrutinib with rituximab, done by MD Anderson, with ofatumumab done by our group, or bendamustine rituximab done by the company, what you see is that the response is a little bit higher, so the lymphocyte counts come down quicker, but it's not clear that patients are doing any better, and probably outside of the setting of a clinical trial, and I would encourage patients to participate in trials that are combining these agents to try to see if there's added benefit. I would probably do Ibrutinib alone. Something else that's very important. This is a special drug. It generally works quickly, but it works, and it's new. And so it's another thing that we hear a lot of doctors calling about, and even sometimes patients is, well, I've started on Ibrutinib and my lymph nodes are getting better, but my count is going up, and some people that are not as familiar with this drug would see that as progression, and that's sort of naturally how this medicine works. And so, it's a new medicine. It's something that patients are going to do themselves well by being educated and be an advocate. And there, say, the Leukemia and Lymphoma Society, Brian, your blog, and other sites. You can get information, because there's a lot of new stuff about this drug, and doctors are busy, and sometimes it's hard to keep up with everything.
And the other thing I would add as a patient is there's potential interactions that you need to be aware of. Grapefruit juice, certain antifungal medications, ketoconazole, mixing this, even knowing about there being a slight risk with surgeries and having to hold the drug for a few days. These are other things that people need to know about. Any other things you wanted to add to that? Or
no, and this is a medicine that you should not be on warfarin. If you develop a reason to be put on warfarin or Coumadin, those two together are an absolute no-no. And it's a drug. It's like any other medicine. Some people tolerate it very well. A subset can develop muscle aches, joint aches, loose stools. And there are a lot of supportive things that can be done for that. And if you're having problems, or your doctor's and your doctor really doesn't know what to do, call an advocate, or ask your doctor to call one of the a CLL expert that has experience with this medicine. I think we need to get the word out. This is a great medicine. It's going to transform what we're doing for CLL. I think there's really not a reason outside of rare cases why a patient with relapsed CLL should not receive this medicine. There are only a handful of reasons that I can think of that you would do chemotherapy if your disease had relapsed and it was time to treat again.
Let me ask you just finally if there's any final thoughts or anything else that you wanted to say that we've learned from ASCO 2014.
No, ASCO finished with a bang. The last three abstracts related to new drugs in CLL. The future looks very promising with ABT-199, the SYK inhibitor, the BTK inhibitors and PI3 kinase inhibitors, and I think it looks very optimistic for CLL patients in the future.
Thank you, Dr. Byrd, for all you do for patients and research in CLL.
Thank you, Brian.